Hello and welcome to our webinar. Today I'm going to be speaking to you on new evidence to support the use of LIPUS on fresh or acute fractures. My name is Michael McKee and I'm the professor and chair of the Department of Orthopedic Surgery, the University of Arizona College of Medicine in Phoenix, Arizona. I've had a long interest in fracture care and in non-union reconstruction, including prospective research and randomized research in both fracture care and non-union treatment. And my particular interest is especially in the recalcitrant non-union and how best to manage that type of patient. I do have disclosures in this area that are relevant and they're listed here. My disclosures are also up to date on the American Academy of Orthopedic Surgery website. The learning objectives of today's webinar are to describe factors that would warrant early intervention for fresh acute fractures, including patients at greatest risk for non-healing and fracture location. So this would typically be the so-called high-risk fracture that we know intrinsically has a high rate of developing a non-union. And we'll talk specifically about what those risks are. And also to examine the clinical data and clinical case outcomes for fresh acute fractures treated with low-intensity pulsed ultrasound or LIPUS. First, I'm going to talk about fracture healing. This is a natural phenomenon that has occurred for thousands or millions of years in adults and children. So what is normal bone healing? This image is courtesy of one of my colleagues, Bob Zura. This is a patient with a subtrochanteric fracture of the femur, as you can see here. The displacement isn't terrible, and the particular fracture pattern is not one that's particularly difficult to treat. We know from the literature and from our own experience that these fractures typically do very well with a closed reduction and intramedullary nailing with some type of reconstruction. A nail is done by Dr. Zura in this slide here. And you can see with time, there's a gratifying obliteration of the fracture line, and there is abundant callus formation, and this fracture is solidly healed both clinically and radiographically in a very short period of time, relatively speaking. This is a fracture fixation which is not completely rigid, but allows some micromotion at the fracture site. It stimulates and encourages bone formation, and yet it's mechanically strong enough to allow the patient early motion and early weight bearing. And this is ideal treatment for this fracture in literature, especially if it can be done in a completely closed fashion, whereby you don't have to open the fracture site to obtain a reduction. If, however, the fracture site remains significantly displaced or has an unacceptable deformity, then often it does require an open approach, but that was not the case here. An open approach may slow down some of the biology of the fracture by destabilizing the soft tissue envelope around the fracture site. Voltaire said, and I quote, "The art of medicine consists of amusing the patient while nature cures the disease," end quote. And that's certainly true then, and it certainly is true now. I would suggest, however, that the modern physician, and especially the modern orthopedic surgeon, has a whole lot more to offer the patient in terms of healing and time to healing than was available in Voltaire's day. And the amount of time it takes for a fracture to heal, and the amount of time it takes for a patient return to full function or their pre-injury status is really of critical importance to many individuals in our society today, and something that we're very focused on. Primary fracture healing. Well, what is primary fracture healing? This is the old classic AO technique where anatomic reduction of the fracture ends is required. There's no gap and there's stable fixation. Of course, in a fracture treated non-operatively, this is rarely the case. You may see some undisplaced or minimally displaced long bone fractures that have a stable soft tissue envelope that heal with primary fracture healing, which is really a type of accelerated bone remodeling. But if there's a displaced fracture, such as the humeral shaft or tibia or femur, then the primary fracture healing is relatively uncommon because it does not have the prerequisites that you are required for primary healing, as you see here. When these requirements are fulfilled, healing ensues via cutting cones, and really this has been described as an accelerated rate of bone remodeling rather than actual true fracture healing. Callus is minimal, and the bone rapidly completes healing across a fracture where there's minimal gap or no gap, and there's anatomic reduction. Secondary fracture healing is a more common form of healing that results in fairly exuberant callus. Both endochondral and intramembranous bone healing occur. It does not require a rigid or stable condition, and again results in callus. And if you look at the fractures we treat non-operatively, such as distal radial fractures, proximal humeral fractures, a lot of elderly patients with pelvic fractures, etc., you'll see this kind of secondary fracture healing where bone isn't rigidly held together. There's a bit of a gap at the fracture site, some micro motion or actually macro motion occurs, and a variety of different mechanisms occur to form callus and heal. And this is, of course, what's been occurring in the human model for eons. There are considered to be 4 stages of bone healing: the acute inflammatory phase. And I'm going to stick with that just for 1 second because this is a very interesting part of our treatment. Most patients assume that acute inflammation is a bad thing. And certainly a lot of the medications that we use these days, anti-inflammatories, et cetera, designed to reduce inflammation. In fact, inflammation is an intrinsic part of bone healing. Inflammation brings the population of primitive responder cells to the fracture site that are going to develop into bone-forming cells eventually. And so inflammation at a fracture is a critical part of healing. And if you look at it clinically or in a basic science model, this is why we think, or it's postulated by some, that the use of anti-inflammatories can slow down bone healing or increase the rate of delayed or non-union. There's literature back and forth on this both ways, but I do think there's probably an element of truth in that the rigid application of large doses of anti-inflammatory medication, especially early on in the healing phase of a fracture, is probably contraindicated, especially in a tenuous fracture or a high-risk fracture. And we'll talk a bit more about what those are. So I don't think it makes much difference in a femur that you nail, whether the patient takes an anti-inflammatory or not, since that particular fracture is a 99% success rate in healing and it pretty well heals every time. But if you have a tenuous fracture, open tibia fracture in a poor biology patient, then it may be that anti-inflammatories might not be the best idea, especially early on. After inflammation, there's the cartilaginous callus formation where there is healing at the fracture site. You don't see much at the x-ray, but there are some cells there that are developing to cartilaginous precursors that are helping to create some stiffness at the fracture site and providing some stability. And then eventually, this results in transition to an ossification, and callus that you can see on radiographs is obviously mechanically much more solid. And this is the healing phase that we see with that fluffy callus formation on radiographs, which is very common. Lastly, once the fracture is healed with passage of time, and this can take years, you see a bone remodeling, so that a lot of the extra callus is remodeled back to original cortex. It can be that the original fracture site is visible for years in some situations, especially, for example, in the anterior aspect of the tibia, but the bone remodeling does occur, and there's solid bony union and remodeling around that kind of situation. What about cartilaginous callus formation? Well, this is key feature of healing. Endochondral formation begins between the fracture ends, and it starts to give the fracture a stable construct. And the generation of this callus is dependent on the recruitment of those mesenchymal stem cells. And these primitive precursor cells, are the cells that are attracted to a fracture site by inflammation. And they are in the hematoma around a fracture, and they're increased by the inflammatory process. And this may be the step which is most sensitive to anti-inflammatory medication in that kind of setting. The recruitment of mesenchymal stem cells suggests that numerous factors have a role, and you can see all these factors here. The ones, of course, that orthopedic surgeons are most familiar with are the BMPs, the BMP2 and the BMP7 when it was available. There's a host of factors that can recruit mesenchymal stem cells. And to make it very simple, most BMPs are protein molecules that say to a mesenchymal stem cell, okay, we want you to become a bone-forming cell. And so that's an important point in the use of BMPs, is that if you don't have mesenchymal stem cells at your fracture site because you have poor soft tissue coverage or you don't have any good vascularity there, et cetera, then BMPs can't work if there's no population of responder cells for them to work on. And that's where the mesenchymal stem cell population is critical for BMPs to work on. In addition, there are a host of other factors that have been investigated. You can see some of them here: platelet-derived growth factors, TGFs, insulin-like growth factors, et cetera. One of the issues when we use BMPs is really we use them in a very heavy-handed fashion. We apply this massive or pharmacological dose of a BMP at one point in the healing process when you have surgical access to it. And that really doesn't recreate the natural, intricate combination of different levels of growth factors at different concentrations that occur with time. And that may be why, on occasion, BMPs are also not that effective clinically. Callus ossification is what occurs when the primary soft callus is resorbed and replaced by a hard bony tissue, and a cascade of factors initiate the resorption of this. And there's an entire family of molecules that help regulate osteoblastic bone formation. So this is a critical part. This is the part you start to see on radiographs and your patient after you fixed a fracture, or after a fracture treatment of some kind going forward. The bone remodeling process is a balance between the hard callus is resorbed typically by osteoclasts, and the lamellar bone is deposited by osteoblasts. And so there's this resorption and deposition process which goes on simultaneously in a carefully balanced model. If it works properly, remodels the fracture site. Obviously, this is much more effective and robust in children, which is why you can see really ridiculous degrees of deformity in children's fractures, especially young children. And literally 3 or 4 or 5 years later, they have almost an unrecognizable fracture site and normal appearing bone because of this process, which is very robust in kids. Well, what is the clinical data available that would suggest that using a LIPUS or some type of other device is indicated in fresh fractures? If you look at early LIPUS treatment in this paper by Jim Heckman from the hospital, Bulletin of Hospital and Joint Diseases, way back in about 1997, it was found that LIPUS treatment reduced the incidence of delayed unions in tibia fractures. You remember, we talked about tibial fractures before as really being the problem fracture in the human body, and any series of non-unions always has a high proportion of tibial shaft fractures in them for that reason. What they found was that there was an 83% relative reduction risk for reducing the need for secondary procedures when LIPUS was used in this clinical setting. So they had a roughly equal number of groups. I don't think this study was randomized, but it was case controlled. And they found that if you use LIPUS early on in tibial fractures, you reduce the incidence of secondary intervention from 36% down to a 6% level, which is really quite remarkable. This represents a relative risk reduction of 36 down to 6 of roughly 83%. What that means is 83% of the time in this study, if you use LIPUS, you could eliminate the need for secondary procedure. I will just digress briefly and say that the need for secondary procedures, unfortunately, is not really a great outcome measure. It is one of the more subjective measures that we use, and it's often dependent upon how the patient, the doctor, or the combination of the two feels about things or what their biases are. But this was a pretty compelling study, this particular degree of risk reduction. What about distal radial fractures? Well, this was actually a prospective, randomized, placebo-controlled double-blind trial. So that meant that the people who were getting the treatment and the assessors didn't know what treatment they got. It was multi-center. It was run by Tom Christensen, or TK, who was from Vermont. And I had the pleasure of visiting him in Vermont a couple times when I was a fellow in Boston, and it was a really enjoyable experience. And TK was a great host and a great doctor. Anyways, he ran this study, and what they found was that patients treated with LIPUS had a 38% reduction in time to healing. And so we spoke before about how not only healing, but the time it takes to heal, or the time to return to function, is critical in our patients. And this would suggest that these patients who had a closed reduction and a cast or splint put on and then had LIPUS in a double-blind fashion had a 38% quicker healing time. And that really was of significance. And this was the impetus for a number of athletes being treated with the LIPUS when they had their fractures. And if you're a professional athlete, I think this has become almost standard of care now for those individuals because of the reduced time to healing, and getting back to sport is obviously critically important for them. This also showed that the 3 cortices being bridged was their outcome measure, which is probably a pretty good outcome measure. And you can see the time to healing is much improved. Also, the use of LIPUS reduced the loss of reduction. So if you consider that your fracture is going to heal quicker, then the chance of it losing reduction is probably less. And this study would suggest that's the case. Remember, these fractures were not fixed surgically. These were typically closed reduction and cast fractures. And we know that in the distal radius in the human model, a significant number of these fractures lose reduction. This often occurs progressively over the course of healing. So it's not a single time point where on day 2 post-reduction, they suddenly lose all of their correction. This is something that occurs gradually. And you can see that on radiographs at 2 and 4 and 6 weeks. And so that if you do have the LIPUS applied in this situation, it would seem that the risk of fracture reduction was less, and that would make sense when you recognize what the clinical phenomenon of loss reduction in this setting is, and that it takes time to occur. If your fracture's stiffening up earlier, this would be less likely to occur, and this was statistically significant, and I would argue clinically relevant. If you can reduce the loss of reduction by more than half, that's clinically relevant as well, in my opinion. So to summarize these studies that you can see there, and there's a number of those, and for the sake of brevity, I'm going to just focus on a few of them, is that there was a 38% faster healing rate of approved standard fresh fractures and an 86% heal rate for non-unions. And there's robust mechanisms of action to support these clinical findings. If you look at what LIPUS does at the basic science level, it can upregulate various factors that are important in fracture healing, especially the ones we're most interested in, the BMPs, and it increases angiogenesis and mineralization at the fracture site. So it may be that part of the effect of BMPs is through angiogenesis. That's a basic science issue I won't get into in too much detail, but there's some evidence that's the case. And these papers here all would support those findings. Well, what about the clinical data? So this is a busy slide, so I'm going to leave it on for a while. If you look at foot and ankle fresh fracture data, there are a number of studies out there. Now, these vary in quality from case series and case reports, which, as we know, are probably on the lower tier of the hierarchy of evidence, all the way up to prospective randomized controlled trials where both the patient and the assessor are blinded as to whether the device that's being used is active or not. And so this is a selection of all these various papers. Some are simple case reports. Others are obviously much better studies. If you look at the Strauss paper on the top row in the Journal of Orthopedic Trauma, they found that with fifth metatarsal fractures, with 20 patients included, that they found a 40% acceleration rate in those fractures treated with LIPUS. Other papers, such as Handelin's paper, looking at malleolar fractures, they did not show as much of a difference. And this is like the literature on any other topic. It's not completely uniform. There's variations, and it may change depending on the bone involved, the fracture displacement, the type of patient that is applied to, et cetera. But that in general, there's a variation of data here, but that many of these papers do show success with the LIPUS. There is a paper from Bob Zira, which was published in 2015. I think we'll go into more detail in a minute, which is a retrospective analysis of prospectively gathered registries data that found that in the lower extremity and metatarsal and ankle, with over 500 patients, the success rate was 98%, which I think is pretty good. So there's some variation in the data, as you would anticipate from any other area in orthopedics or medicine, but in general, it's fairly favorable in the foot and ankle area. If you look at Strauss's study in particular, this one looked at the patients we just spoke about, 20 patients with the zone 2, the Jones fractures, which we know at times have a difficult rate of healing. These are ones that are more distal than the simple avulsion fractures. And 10 patients had no treatment or control treatment with a splint, and the others had the adjuvant treatment with ultrasound. And they found that, and this was interesting, they used the ultrasound for 20 minutes twice a day, which is usually more than we use in the non-union world. They found that there was significant improvements in these patients. Healing was accelerated by 40% compared to fracture control group that healed, and that all 10 fractures in group A that had the ultrasound healed at 6 weeks, whereas 6 patients in the control group had healed, and the other 3 went on to non-union. So the numbers are small here. So this is where we could talk about a potential beta error. If you look at 3 non-unions out of 10 versus 0 out of 10, those numbers aren't probably big enough to show statistical difference. In my opinion, a situation where this may be a beta error, and that this is probably a true difference, but that the numbers of patients are just too small to prove it statistically. And if instead of 10, one had, for example, 100 patients, then I think that would probably statistically confirm what we suspect might be clinically true. So the results in this situation show that maybe you can also reduce the overall non-union rate and not just improve the time to healing. Bob Zura, as you know, who's the chair in New Orleans, has a long-standing interest in fractures treated with LIPUS. He's a very skilled and experienced traumatologist, and I very much enjoy hearing his talks. And this was a patient he presented with Samir Mehta and Greg Della Rocca back in 2015, looking at a cohort study of over 4,000 patients treated with LIPUS, and looked at what the results were in this group. Overall, they found that the healing rate for all fractures was approximately 96%. And you can see that elderly patients treated with LIPUS have a heal rate which is comparable to the overall patient population. We know that in the elderly patient, there are a number of problems with fracture healing. We discussed some of these in other situations where they may have metabolic issues that make it difficult for them to heal fractures. The nutritional status may not be optimal. They may have a number of common comorbidities that affect fracture healing. Their ability to comply with non-weight bearing or partial weight bearing regimens may be compromised by muscle weakness or imbalance, etc. If they are fixed surgically, we know that poor bone quality in many of these individuals may lead to early hardware failure. So we know that's a very difficult group to get to heal. But in this study, we found that the healing rate in elderly patients was gratifyingly high and really quite equal to all comers. So it would suggest that in a high-risk population, that the application of LIPUS may help give you a heal rate which is comparable to the general or overall patient population that we treat. Next, we'll look at this observational study, again by Bob Zura, looking at treatment of fracture non-union with LIPUS in a cohort of over 700 patients. To be applicable for the study, the patient had to have a fracture which had not united after a year after the fracture. And some of these patients had had up to 10 years of established non-union. In addition, they had a mean of 3.1 prior surgeries. So as we can recognize, this was a fairly compromised group. Now, this study gave us essentially 4 data points: the time of the fracture, the time of LIPUS application, the time of LIPUS discontinuation, and what the outcome was. And the outcome was a fairly simple outcome: binary, union or no union. So this kind of study doesn't give you finesse data about function, range of motion of the joint, patient-related outcome. It just says when they had the fracture, when the LIPUS was applied, and then whether things healed or not. And so there is some usefulness in that kind of information. What they did find was that the healing rate, very surprisingly, was 87%. So if you can get 90% of your non-unions to heal by applying a LIPUS, then that's obviously very beneficial for the patient and also helps avoid further surgery. And even in patients who have a 10-year history of non-union, multiple failed prior surgeries, this was still a very effective technique. Nolte looked at a specific fracture, the metatarsal fractures. This is a paper in the European Journal Injury in 2016, and they looked at a propensity match study of patients. So this isn't a randomized trial, but it's a match study. So they match patients in the control group with the same characteristics, same comorbidities, age, gender, fracture type, etc., looking at LIPUS versus other treatments. Their hypothesis was that metatarsal fractures treated conservatively with LIPUS would obtain healing rates comparable to current surgical techniques. This looked at almost 600 metatarsal fractures, including 161 Jones fractures. And as we spoke about, those are typically fractures that are difficult to get to heal. The LIPUS patients were propensity matched to fracture patients in the health claims database that included almost 90 million patients. So it was quite easy or straightforward to get a good matching when you have so many patients to choose from. Once they excluded registry patients who had received surgery, the healing rate with LIPUS alone was significantly better than the healing rate for matched patients. So if you take away the surgical patients and you just look at control patients in the registry versus those who obtained LIPUS, there was a significantly better heal rate for the patients who had LIPUS, as you can see here in this slide. Additionally, metatarsal fractures treated with LIPUS alone had a heal rate comparable to those treated with surgical intervention. Now, you could argue that there may be some selection bias here and that only more complex fractures were treated with surgical intervention. That's probably true to some extent. But overall, it's compelling evidence that for metatarsal fractures that have reasonable alignment and that don't need to be surgically corrected for that reason, LIPUS A will give you a success rate similar to surgery, and B, this is probably significantly improved compared to those who don't have a LIPUS application, as you can see in this slide here. There are similar studies done in the delayed treatment of foot fifth metatarsal fractures. This article was published in Foot in 2018. Now, this was a retrospective review, and we know that there are some issues with retrospective reviews in terms of a bias and lack of follow-up, et cetera. But they looked specifically at the use of LIPUS in treating delayed union of fifth metatarsal fractures to see what happened essentially. This study divided the fractures up into various zones. So zone 1 to zone 3 and then down in the shaft. Typically zone 2 are what we would describe as Jones fractures. And you can see that they had a fairly good number of patients here, and mainly in Jones fractures. And the Jones fractures are mainly female patients, as is often the case. And you can see the primary treatment here in general is an air cast boot or some kind of baloney cast or shoe. I will say that there's some recent information available from prospective studies looking at the type of immobilization for fifth metatarsal fractures. And to put it very simply, of course, there doesn't seem to be a whole lot of difference in the various non-operative or immobilization techniques for most of these fractures. And there's some recent data to support that. What they found is that 27 out of 30 fractures healed, and that 3 fractures failed to heal, and those were treated with LIPUS for a prolonged period of time. 2 eventually had surgery, 1 was asymptomatic. Again, as we have spoken about in some of these seminars today, is that smoking is definitely a risk factor for not healing. If you look at this group, all 3 fractures that didn't heal were smokers out of only 8 in total. And so that means that by my math, 22 out of 22 non-smokers all healed their fracture. The average fracture gap was significantly bigger in fractures that went on to non-union, as you would expect. And this may be where some of the bias comes into the study like this, where the bigger fracture gaps may have had surgery or not been included here. But in any event, as we'd expect, LIPUS isn't going to fix everything. And if you have a smoker with a large fracture gap, that may be a patient that's going to be particularly difficult to get to heal. But apart from that, the treatment was pretty successful in this delayed healing group. Fortunately, there's an abundant amount of evidence looking at LIPUS specifically in the foot and ankle. And these are all reviews and meta-analyses that include data on the use of LIPUS in this area. And there's a number of different papers here you can read from a number of different well-respected and authoritarian authors. And I would encourage you to do so. These slides will be available online if you want to look at them. And if there's a particular area of interest to you, you can look at there's almost always a good review in that area from one of these authors, looking at fracture healing, non-union healing, et cetera, in this area. What about LIPUS clinical data for fresh fractures? There's fortunately an abundance of that as well, and we'll go into some of these in detail. This is a paper published on the effect of pulsed ultrasound on fresh fractures. It's a meta-analysis done by a Chinese group and published in the journal Medicine in 2017. These are authors from the People's Republic of China who have looked at this in a systematic way with a meta-analysis. Their study included papers from 1980 till 2016, and they were all 30 high-quality studies that they were randomized controlled trials or quasi-randomized controlled trials. And as you may be aware, to digress briefly, there's a scoring system for the quality of randomized trials called the Detsky score. And the Detsky score is out of 20, 22, I think, for surgical trials, and it describes whether the authors were blinded, what the rate of follow-up was, the size of the study, some of the statistical qualities of the study, et cetera. So you can actually grade the quality of randomized controlled trials using the Detsky score. The exclusion criteria was trials comparing LIPUS specifically to other interventions. Osteotomies and distraction osteogenesis were not included. And as an aside, I've also found LIPUS to be quite successful in distraction osteogenesis in my old Lisroff type practice. They found 12 studies to include in their analysis that adhered to PRISMA guidelines and were pretty high grade. And what their outcome measures were time to fracture union, the subgroup analysis, quality of life. So these are studies that did give us some quality of life outcome or functional data from patients, including weight-bearing return to work, which is really very critical information for us. So this is better information than we obtain from some of these observational registry-based studies. These are some of the studies here, some of which we've already discussed, the ones by Jim Heckman and T.K. Christensen on the tibia and distal radius. And you can see here that there's a number of studies, 12 in total, and that the overall conclusion was that LIPUS accelerated fracture union compared to placebo with a significant p-value that was not only statistically significant, but also, I would argue, clinically relevant. This is what's called a forest plot. And a forest plot basically looks at all the various studies and weights them according to their size, which is essentially the number of patients involved, puts the green dot on the side of the line where either favors LIPUS or favors control. And then the black diamond is a cumulative effect of all of these studies. And the diamond is the size relatively of all the studies combined. So you can see here that in general, the studies favor LIPUS compared to control. The edges of the diamond represent the confidence intervals. If the diamond overlaps the central line, it means that, well, there's a difference, but the confidence intervals overlap, so it may or may not be true. But when it's clearly on one side or the other, as it is in the lower group, which compares LIPUS to conservative or non-operative management, it's clearly superior according to this. Then that makes a clear-cut argument in favor of LIPUS. It may not make as much a difference in operative management. Those are the studies in the top half of this graph, but certainly overall with conservative or non-operative comparisons, it really makes a big difference. I mean, you total them, it makes the improvement as you see in the bottom diamond there. So operative, it's hard to say, no clear-cut difference perhaps, but with conservative treatment, definitely LIPUS was superior to non-operative treatment. This looks at time to fracture, definition of fracture healing. It varies, as we know, from study to study and from bone to bone, but radiographically, it would appear clear that the LIPUS application did improve the time to radiographic union. If you look at time to clinical union, and we recognize it's a very difficult thing to define accurately. Now, that confidence interval is very wide. That if you look at the shape of that triangle in the forest plot, that would indicate there may be a difference, but certainly the confidence intervals overlap the central line, which means you can't be sure of it, and the corresponding p-value is not statistically significant. So in a more nebulous definition of union, it's not as clear-cut, but certainly radiographically, it seemed to improve things. So to summarize this meta-analysis, it was that LIPUS treatment accelerated healing in fresh fractures and had similar benefits to operatively treated fractures. And subgroup analysis showed that this accelerated union in conservative treated fractures, upper limb fractures, we talked a bit about the difference between upper and lower extremities there, and the radiographically defined healing parameters when treatment was less than 6 months. So there's also data from the study, which we didn't present here for sake of brevity, that shows improve the quality of life significantly, which is important for our patients. So what is the LIPUS treatment pathway? Well, let's discuss that. Now, this is a bit of information here, so I'm going to go through this slowly. So the first thing you need to ask is my patient's fracture suitable for excision? So is this a fresh fracture that has poor healing qualities? Is this a delayed union? So this bone is taking longer to heal than a typical bone of this nature would, or is this a frank non-union? So in this kind of setting, if your patient qualifies as a fresh fracture that has some potential for poor fracture healing, or an at-risk fracture, delayed union compared to what you would typically expect, or an established non-union, that definition differs. For most bones, it's no healing at 6 months, or perhaps a plateau of healing for 3 months or more, then your patient may be eligible. If your answer to these 3 questions is no, then it's probably not going to be beneficial to use a LIPUS. If you look specifically at the fracture itself and what are the fresh fractures that have a poor track record, we'll talk a bit about that. But is the fracture stable? So we know that if there's a grossly unstable fracture with unacceptable deformity, then probably this is not going to be something which is going to be that helpful. But if you have a stable fracture, then LIPUS is an excellent non-invasive treatment for those patients. Is a fracture gap less than 10 millimeters? We know from a number of studies that, and this is debatable, and we talked a bit about critical size defects in adults. We know that fracture gaps typically result in non-union. We have clinical evidence that a gap of less than 10 millimeters does not seem to negatively affect the effective LIPUS, and so that fracture is still eligible. If it's more than 10 millimeters, depending on the bone, of course, we generally consider that to be a critical defect that would mean a LIPUS treatment is not suitable. And if I can digress for a little bit about what a critical size defect is in humans, it would seem from the SPRINT study, which was a large randomized trial looking at tibial shaft fractures comparing ream versus unreamed nails that was organized and run by Mo Banderi. They looked at the patients in that study that had a critical size defect in the tibia. And a critical size defect is one that is generally considered to be one so big that the non-union is probable and that some other intervention will need to be done following primary fracture fixation to get that fracture to heal. In their study, a majority of the critical size defects that they defined early healed without further surgical intervention. So it's interesting that even our definition of or understanding of what a critical size defect is may not be accurate. But in any event, if the fracture gap is less than 10 millimeters, then it's probably still eligible for use of LIPUS. And lastly, is the fracture complex? So is the fracture one which was originally open, a comminuted, poor soft tissue or vascular coverage? Now, this is a bit debatable. You need to have soft tissue coverage of your fracture for an excision to be indicated, obviously. But if they have these other risk factors that make it more complex, and again, this may be a fracture at risk, which is eligible for a LIPUS application. Does the patient have a fracture in a location associated with poor fracture healing? So we know that some fractures really have difficulty healing. And the upper extremity, the one that gives us the most problems, of course, is a scaphoid fracture. And recognizing that, there are a number of studies that would suggest that LIPUS can significantly accelerate the healing of fresh fractures, including both registry studies and randomized trials. And so scaphoid fractures may be ones that are particularly suited for the use of a LIPUS. Metatarsal fractures, now not all metatarsal fractures, because most of them do heal, as we know, but a Jones fracture in a particular area of the 5th metatarsal, it's more distal than the usual avulsion fracture, and not really a shaft fracture. The fractures in those areas have a non-union rate, which in some series is as high as 25 or 30%. So we know that when you have a fracture like that, especially in a biologically compromised patient who's got medical comorbidities, maybe a smoker, et cetera, this may well be a good indication for the application of a LIPUS device in the acute fracture setting a high-risk fracture, especially in a high-risk patient. And then lastly, of course, are tibial fractures, where we've already discussed that the rate of tibial non-union is extremely high, both in my own practice and in the medical literature. And by that, I mean much higher than other fractures. A nailed femur fracture, for example, is a 98% or 99% healing rate in most series, where certainly that's not the case with the tibia. And if you look at the SPRINT study, there was a significant rate of operative reintervention in tibial fracture treated with IM nails was much higher than what you see in the femur, for example. So we know that this is a complex fracture, especially in patients who are compromised biologically by either smoking or metabolic diseases. We know that there's evidence in patients with fresh tibial fractures that LIPUS has improved healing rates and decreased the time to union in a number of these cases. So these three specific bones, there's evidence in literature, and some of these are high quality randomized trials that would suggest LIPUS application may be beneficial for your patient. These are some of the things that I spoke about specifically in the other session. What about smoking? Well, we know that smoking is bad for fracture healing. I think every one of us who works clinically recognizes that. There's multiple papers that clearly show that, multiple papers that show that with a Lizeroff reconstruction, with scaphoid fractures, with tibial shaft fracture, et cetera, that a patient who's a smoker has a risk factor for not healing. We also know that intervention in that individual to get him or her to stop smoking also may be beneficial. There's one or two randomized trials that suggest that. So in addition to using an Exogen in that specific situation, you may find that a smoking cessation program can definitely help your patient get their fracture to heal. Is the patient a diabetic? Well, especially in the lower extremity or neuropathy, that really complicates matters. If they have a vascular insufficiency problem, that can affect bone healing. A neuropathy can affect the amount of stress or force seen by the fracture, et cetera. And so there's good evidence that some type of LIPUS device can help the diabetic patient with a fracture. Is there poor vascular coverage at the fracture site? Well, again, this is hard to define objectively, but we know that if there's higher energy trauma and a lot of soft tissue or periosteal stripping, either during the trauma itself or from subsequent surgery, this can be a major cause of atrophic non-unions. And there is a lot of evidence that in the basic science and preclinical models that an ultrasound device can accelerate healing in this kind of setting. And there's some clinical evidence as well. And lastly is the patient elderly. As we discussed, elderly patients have difficulty with fracture healing for a number of different reasons, including a poor bone quality, nutritional deficits, cognitive impairment that compromises compliance, et cetera. And so we also have evidence, as we spoke about in this specific webinar, that Exogen can result in a very high healing rate in elderly patients at risk for non-union. So these are some of the risk factors that we have that are associated with poor fracture healing. And this is not meant to be an exhaustive list. There's other issues such as bariatric surgery, potentially. These are not specifically investigated with LIPUS, but these are some of the things that as a practicing clinician, we see: vitamin D and calcium metabolism patients, renal failure patients, bariatric patients. I'm not suggesting that LIPUS is indicated for all of those, but those are potentially some of the patients we see who have issues with fracture healing, in addition to the list you see here. There's also clinical evidence in osteotomy patients. And this is nice because it's a very controlled setting where you can standardize the tibial fracture, so to speak, by creating a consistent osteotomy. And this Japanese study showed that LIPUS treatment can significantly improve the healing rate of these opening wedge high tibial osteotomies for varus knees in this study published in the JBJS American in 2004. There's also a fair bit of evidence on this topic in regenerate bone formation, et cetera. In stress fractures, and this is a common thing that we see, especially when there's the female athlete triad of malnutrition, overexercise, and stress fractures in the tibia or the femoral neck. There is evidence, again, from this Japanese study looking at anterior mid-stress fractures. These are pretty clear cut with a very hot bone scan and some radiographic changes as well. And that adding LIPUS to these did seem to improve the healing rate. And these patients got back to sports an average of 3 months after the onset of treatment. This is a very difficult area to define. All of these are a bit different. The biology of the patients is poor. The amount of exercise they do is often excessive, and usually this is a balance between the bone's ability to heal and the patient's amount of exercise and nutrition. But it would seem that this is pretty accelerated compared to what most of my patients with stress fractures, very few of them be back full bore sports activity at 3 months. So it may well be advantageous in this setting to use a LIPUS type device for these patients, in addition to the usual treatment, which the mainstay of which is to decrease the amount of stress and exercise the involved bone sees. Bone transport, I used to have a fairly robust Ilizarov practice back in the day, and this include both regenerate bone for filling segmental defects and also bone transport, limb lengthening, etc. There's evidence from Stuart Gold's study back in JOT in 2005 that there was a significant acceleration as measured through the external fixator index, and that's how long does the frame have to stay on to produce 1 centimeter of regenerate bone. The lengthening index is what Ilizarov used to call it, I believe. And there is evidence in this specific situation that LIPUS may help bone regeneration. Certainly, I had a number of patients in the regeneration phase that had completed their lengthening or completed their transport, had poor bone quality in the poor regenerate bone formation that seemed to be significantly improved by the application of a LIPUS device, and would dramatically improve the quality of bone. So you get the external fixator off more quickly, which is, of course, of primary interest in many of these patients. So that's a fair bit of information for everyone to absorb, and I'd like to thank you very much for your attention, and I'll stop there for the question and answer session.
Hello, everyone, and I certainly hope that you enjoyed this last talk. We'll now proceed with the questions and answers, and there have already been a number of questions submitted, so I'll begin with those. The first one is a question from a participant who states, for distal radius, the data was operative or non-operative fractures and what age? In general, I stopped casting considered healed at approximately 6 weeks, so I'm unclear of the advantage. So I believe that refers to Dr. Christensen's study looking at a randomized controlled trial of distal radial fractures treated non-operatively. So these are fractures who had a closed reduction and a cast applied for a distal radial fracture. And these were then randomized to either a ultrasound device or to placebo. And it was a blinded study, so there was a sham device for the control group, and the results were read by a blinded radiologist. So it was pretty sound scientific study. What they found was that if you look radiographically at the healing of the distal radial fractures, there was a significant acceleration at pretty well every time point for the LIPUS group. And this was statistically significant as well. And remember, the definition of radiographically healed and when you can actually take a cast or splint off may be two different things. This study was designed to look specifically at the radiographic healing, and the removal of the splint and the cast was up to the discretion of the investigator or the surgeon in the study. And so it's a bit hard to mandate when you can take a cast off, but radiographically, certainly, there was significant improvement in the LIPUS group. Now, what did this translate to clinically? Well, in the LIPUS group, and by the way, the age was, I think the mean age was around 55 or 56. These are patients older than 20 years of age, and the mean age was around 55 or so. What was the clinical significance of that improved healing? Well, number one is they found that for this group that had a closed reduction, there was less loss of reduction, especially volar tilt triangulation in the LIPUS group. So it was about half that of the control group, and this was also statistically significant. So number one is the clinical advantage was a less loss of reduction to a clinically significant degree. The second was that in general, the casts were taken off earlier, but this was not statistically significant. And then splints were applied, and there's a variety of different immobilization techniques. So that's where it becomes a bit hazy and difficult to be exact about it. So I would say that there may well be a clinical correlate where you can remove the casting and get someone moving earlier, perhaps into a removable splint in the LIPUS group. Although this was not statistically significant in the study, it may be going forward that you'd find that in an individual patient who had earlier radiographic healing, you felt comfortable as the treating clinician to remove the cast or splint earlier. So that was kind of the clinical correlation of that study. The second question that's been asked is LIPUS being covered by insurance prior to 90 days? Several reps have told me that there had to be poor healing prior to approval for use for 90 days. Are you using the early period? So this is a complex question, and I would point out that I'm not an insurance or authorization expert. I have people in the clinic who deal with that difficult issue. What I would say in my own experience is that if I have a patient who has a high rate of non-union statistically from their demographics, so smoker, difficult fracture, diabetic, one of those issues that we know leads to delayed healing. And I really feel that this would be a situation where LIPUS would benefit the patient. Then I have been pretty successful in getting approval early. Often that means a peer-to-peer call, and I found that to be a very effective way of making the case for a patient. And the argument I use is, look, this patient has a very high rate of delayed or non-union. If you look at the literature with this particular fracture and the particular risk factors that the patient has, and it would be everyone's best interest if this fracture healed and did not go on to a delayed or non-union for a variety of economic reasons, if nothing else. And usually in a peer-to-peer call, I've been successful in arguing that position and getting something funded for it. So I think there's wide variation between where you are, what kind of insurance plan you're dealing with, how skilled your rep is at getting this done. But in general, I think if you back it up with a peer-to-peer call with some common sense information and data on your particular patient, then I think that's quite beneficial. I have one other question that asking about atypical femur fractures, and is there any benefit in using LIPUS in an atypical femur fracture? Well, I do have some experience in this, and maybe I'll relate that. It's clear that patients who are on long-term bisphosphonate therapy have bisphosphonate associated or atypical fractures, usually typically of the proximal femur somewhere. It's also clear from the literature on this topic, especially the early literature before we really understood what we were dealing with, that there's a dramatically increased rate of delayed and non-union in those patients with early treatments, especially if you choose a device which is not optimal, such as a pin and plate or a plate of some kind as opposed to a nail. And even with the nailing, there are some technical aspects that are critical in order to obtain union, such as trying to get good reduction, leaving it no barrier. Some people routinely open these fractures, put a small plate on laterally to get good reduction prior to nailing. The tight proximal canal, especially in small stature patients, often don't accommodate a large cephalomedullary nail. And it's a major issue, obviously. I have had experience with LIPUS in 2 patients that I can think of, and where we had delayed healing at 6 or 7 months after one of these fractures. And in those 2 patients, it seemed to be very effective. So I can't say for sure on a statistical or a large database type of issue whether this is useful, but it would seem to me that this is definitely a fracture that has an increased delayed or non-union rate, and definitely a situation where anything you can do to speed that up is beneficial. And as long as the fracture is stably fixed, and typically it is with a nail of some kind and reasonably well aligned and not infected, this same provisos we've used in other areas, then I think LIPUS can be very typical, very helpful in atypical femoral fractures as well. And I've used that twice to good effect, where the amount of healing increased rapidly after the application. Now that may have just paralleled what was going to happen anyways. I can't say that's not the case. There is no good prospective randomized study like the other ones we talked about, but in general, I think it's not a bad idea. And in a similar vein, I've been asked before about periprosthetic fractures. Again, those are fractures that we have a lot of difficulty with getting to heal, and I've also used it in that situation as well to good effect. But again, there's very limited data to support that. So I think in the absence of any other questions, I will stop there. I'd like to thank everyone very much for their participation today, and we will look forward to the next session.